myself, I will echo Anand's sort of call and plea for having someone who identifies as a female or non-binary join us in the lukewarm seat. This is the best way to learn. It really activates us and kind of puts our thinking to the test, and we have fun and learn together. So if you're willing to present a case and join us to discuss, we would love to have you. Happy birthday, Drew, by the way.
And while we are waiting for our volunteers to jump into the chat, let's go ahead and have our scribe and team member that's going to be helping us with the teaching points introduce themselves as well.
Hello, everyone. I'm Valeria. You can call me Vale. I am from Peru, and today I will be scribing. I just recently joined the VMR team and super excited to hear you all discuss and learn a lot. And please volunteer to present a case or discuss. It's really, really fun. And there's no better way to learn than being in the lukewarm seat. And with the guidance of these two amazing persons, so please volunteer.
Hi, everyone. I'm Gurleen. I'm a fourth-year medical student, I guess almost graduated. I'll be graduating next week and starting intern year soon. So I'll be doing teaching points today. And yeah, please volunteer to discuss with Smita and Anand. And if someone has a case, that would be great.
So while we are waiting, I'm gonna filibuster a little bit. Anne-Marie, who is a huge part of our VMR team and in the audience today, had talked a little bit about kind of transitions as she's now coming towards the end of her first year as a hospitalist after residency. Oh, it looks like, so we've got a case presenter. We've got Rafa. We just need two people to jump into the lukewarm seat as discussants with us. So while we're waiting for that, I wanted to kind of piggyback what Anne-Marie had talked about a couple of weeks ago. As I'd mentioned, I am finishing my hematology oncology fellowship, and I will be transitioning to my first faculty position here in a few weeks. I'll be staying at the University of Chicago and joining their group of leukemia docs. And from that perspective, what I can talk about a little bit is the lens you see your patient in the sense of primary team versus consultant or otherwise can really be, can be quite varied depending on kind of the hat you're wearing. And similarly, when you're taking care of a patient and you're presenting that patient to whether it be someone you're consulting or your attending physician or otherwise, the lens that you kind of put that patient in can be very different. I know we have lots of folks in the audience that may be making that transition from either preclinical to clinical rotations or from a clinical rotation to then graduating and then directly taking care of patients as one of their primary providers. What I'll kind of urge you to think about is when you're thinking about how to frame patients, think about how to go about doing it in such a way that the person that's listening on the other end of the line in that 30 seconds, they kind of know exactly what the question is and what relevant data kind of is already at hand. So it's almost like, much like we mold our problem representation across the course of a case during VMR, you're kind of molding that problem representation to the person you're presenting to. In my mind, I'm just trying to think of as I'm in that consulting role and kind of primary role, because we take care of our own leukemia patients in the hospital. We also consult on patients that may be admitted to other services or in the ICUs. I'm kind of figuring out the best way to kind of balance those two approaches at the same time in terms of wearing the hat of the primary team and then also the consultant for a patient. So let Rafa introduce himself while we're still waiting for our two discussants to join us in the lukewarm seat. Rafa, how are you, my friend?
Hi everyone. My name is Rafael. I'm the last year medical student here from Brazil. And I'm also a CPSOVC member. Super exciting to be with you guys here tonight. And I highly recommend you guys discussing. Every time that I discuss or I present a case, I always learn so much from you guys. And hope you can join us tonight. And if you have any tips about how to intubate a patient properly, please share. We're discussing about it before.
All right. Well, I know Maria has volunteered to discuss if no one else would like to. Thank you, Maria. And it looks like, is it Leonardo? Leo, perfect, is also volunteering to join. So thank you so much to you both. Maybe we can have y'all unmute and introduce yourselves. And Anand, thank you so much for that wonderful reflection. I kind of wish that you had been there as I was starting my intern year, so I could have framed the questions appropriately. Thankfully, there were many wonderful consultants like you to guide me along the way.
Hi, perfect. I'll go first. My name is Maria. I'm from Guatemala, and yeah, I'm really excited to discuss, especially with Leo. If you don't know Leo, he does amazing translations of tutorials to Spanish. So he's a great guy. I'm really excited to discuss with him.
Awesome. Leo, do you want to tell us a little bit about yourself?
Yes, my name is Leonardo. I'm a medical student from Argentina. I'm in my last year as well, and so happy to be here. I have discussed a few times before, but never with Maria, so I think this will be fun.
Great. Well, thank you so much for pulling up the screen, Valeria. And Maria, why don't the two of us link up and discuss together, and we'll let Smitha and Leonardo pick whether they'll want to take aliquot 1 or 2, and then we can turn things over to Rafa and go from there.
Perfect. Leo, maybe you and I can take aliquot 1 if that's okay. Does that sound okay, Anand and Maria? Perfect.
Okay, so this is a 81-year-old female presenting with spontaneous bruising. The onset was 2 weeks ago. She developed a large, atraumatic, expanding ecchymoses on her bilateral upper and lower extremities. And this patient denies previous history of easy bleeding and bruising. And that's the end of aliquot number 1.
Oh, Rafa, this is fire already. I am loving it. Leo, when you hear about this history of subacute onset of bleeding, what comes to mind for you?
I think 3 things are the things that come to mind. One, first is to know if it is something genetic in the patient, or if it is something acquired, and after that, if it has something to do with medications she's taking, or if it has to do maybe with another type of problem, maybe a bone marrow problem. And then the other thing I want to think about is if it has to do with platelets or with coagulation cascade. Those are, I believe, the 3 things that come to mind first. So in this age group, I believe atrial fibrillation is quite frequent. So this population tend to be often anticoagulated. So I would like to first, for example, here in Argentina, it is very common to see patients with warfarin or acenocumarol, for example, the anti-vitamin K agents, because the new anticoagulants agents are not so available here, especially in the public sector of health. So maybe these patients do not do the adequate controls, and maybe their INR, I don't know how to say it in English, I believe it is INR. Okay, Maria is telling me it's okay. Goes away from the ranges we want. So maybe it is like something iatrogenic, yeah, because of a lack of control, or maybe because of foods she's taking that alter the INR. But I am also keeping in mind the possibility that it is a new thing, an acquired thing, and well, basically that, rule out the medication first and then see if it has any other accompanying symptoms, if the patient has anemia or any signs of infection, for example, or any masses, hepatosplenomegaly, for example. And well, I think that's what comes to mind first.
Leo, that is brilliant. I loved how you taught us an approach to just bleeding in general. And then you layered on the patient's age and demographic information to modify how you're thinking and prioritizing the different causes of bleeding. And then your like really practical approach of like, okay, in real life, what would I actually be doing? Which is exactly what you said, which is running the med list and then thinking about, is there anything else in association with the bleeding that I can kind of anchor onto and draw a Venn diagram around? And I think about bleeding in the exact same way you do, which for me, I kind of just separate into two buckets. The first bucket, I think about clotting. And so you mentioned all of those things, including platelets. Are there enough of them? Are they functional? Coagulation factors, again, are there enough of them or are they functional? And then mechanical issues. And when I think about mechanical issues, I think about the vessel itself. Is there something wrong with the vessel that is not able to keep the blood inside? And so what goes wrong with the vessels? Well, you can have soft tissue abnormalities, so collagen vascular defects. You mentioned genetic causes, something like Ehlers-Danlos, certainly not in this demographic at 81 years old, but other acquired collagen disorders, including vitamin C deficiency, so scurvy can also cause collagen issues, and then other things that can affect the vessel integrity as well. So things like vasculitis, so inflammation of the vessel wall. Other things like amyloid can cause that, where you get deposition within the vessel wall that actually compromises the integrity of the vessel wall. So that's kind of exactly how I'm thinking about it, these multiple buckets. And then hopefully we'll learn a little bit more about the patient, what background she has. Does she have comorbidities for which she's on anticoagulants, or are there other things like liver disease that would predispose her to having problems with bleeding? So I'll pause there. Really excited to learn more and just like blown away by your discussion, Leo.
So past medical history. This patient has essential hypertension, hypothyroidism, hyperlipidemia, and anxiety. When it comes to past surgical history, this patient has a remote breast biopsy and skin biopsy. The pathology results were benign for both. This patient's family history, the mother has type 2 diabetes and ovarian cancer, and the father had a stroke, and there is no known familial issues with easy bleeding. When it comes to medications, this patient uses metoprolol, levothyroxine, gemfibrozil, and lorazepam, and gemfibrozil as well. Social history, she's married. She's a never smoker. She's never used drugs, and she's an infrequent alcohol use. When it comes to the review of systems, she also reports dizziness and progressive fatigue. She denies pelvic fullness, obstipation, tenesmus. This patient also denies unintentional weight loss, fevers, or positional lightheadedness. And this patient also denies epistaxis, gingival bleeding, melena, hematopsia, or vaginal bleeding. And that's the end of aliquot number 2.
Rafa, do you actually mind giving us the physical exam as part of this aliquot as well?
Sure, no problem. The temperature was 36.8. The heart rate was 65. The blood pressure 85/47. Respiratory rate 14, and she's saturating 98% on room air. Generally speaking, this patient is well developed in no acute distress. Her HEENT exam shows a normal conjunctiva, moist mucous membranes, no oral bleeding or oropharyngeal petechiae. The lungs are normal. Cardiovascular exam is normal as well. The abdomen is normal as well. Regarding her MSK exam, there is a lower extremity edema, 1+, but no joint swelling. And regarding her skin, there are multiple large ecchymoses on bilateral upper and lower extremities, and a small bruise on her lower abdomen, and no bruises on the trunk.
Wonderful. Thank you so much, Rafa. Maria, what's going through your mind right now?
I've always struggled with heme. So this is like a great case to just like get like that mindset of I don't know anything about heme to maybe like I know something about heme. And I really like the approach that Smitha and Leonardo shared about bleeding. It's interesting because she doesn't seem to have any sort of abnormal bleeding anywhere, just bruises. So like nothing else is bleeding, which makes me wonder. At the beginning, I thought she only had like one large echymotic thing in her extremity, but now it seems she has them in all of the extremities. So she's definitely having like a problem, and it's not just an isolated trauma, for example. And then I was thinking, maybe if it's just one, it might be like an isolated trauma. And then she does have like some risk factors for just falling, like falls as a whole. I always tend to think about them with like elderly patients because they might not refer it, or they might not even know that they're getting clumsier. So this is like an older patient, and her blood pressure seems kind of off. So I'd like to check, like orthostatic vital signs to see if like we've gone like a little too hard on her blood pressure medications. What else? I mean, she doesn't have any like other risk factors. What does make me worried is like her constitutional signs. So the fatigue, I know that is very non-specific, but in older patients with like very non-specific constitutional signs, I like to think about like smolder diseases. So maybe like the chronic leukemias or like the myelodysplastic syndromes, like nobody really consults for them just because the symptoms are not like very worrisome for them until like they have something to consult. But like thinking about smoldering cases of everything smoldering plus echymotic everything in extremities. So thinking maybe she's not bleeding, and if she's not like actively bleeding, or she doesn't have like hemarthrotics or anything, maybe thinking of like platelets, and maybe not as much as the number of platelets, but the qualitative disorders of platelets. So I know, like, for example, I think you can get like anything that is caused by antibodies. I think you can get them like for a number of reasons. So for example, like a perineoplastic syndrome or like other diseases. So maybe like thinking, what antibodies can she create that make her platelets not work as well? So thinking about that, and then if it's not like in the platelets, I will have to see through the heme, maybe thinking about like acquired coagulation disorders that I know that you can also get, I forget that. I forget the thing that you get that you can see if you have them with mixing studies. But yeah, I'm kind of not sure at this point about anything.
Maria, for being not sure, you did an excellent job of talking about what we need to do next for this patient. I'll only add a couple things. So kind of building off where Smitha and Leonardo left us, kind of looking through this past history, the things that I am kind of looking for are past procedures. So she had a breast biopsy. Were there bleeding complications with those procedures? And, you know, based on the history that Rafa gave us, it seems like no. So it seems like she's tolerated surgery / procedures in the past, which is important. The next part is medication. So is there anything that's going to make her more likely to bleed? Doesn't really seem like it. Metoprolol, levothyroxine, lorazepam, and gemfibrozil. We'll talk a little bit about how metoprolol may be impacting her vital signs when we get there. Family history, no family history of bleeding disorders, it seems like. Social history. So the reason that this is important, and I don't know if this was just a United States phenomenon or a worldwide phenomenon, but about a year ago, actually a little more than that, about 2 years ago, there was a huge outbreak of spontaneous bleeding due to people using synthetic marijuana because it had warfarin derivatives in it. And there was a New England Journal report about it. And yeah, so you know, past history, sometimes if they're drugs that aren't maybe as tightly regulated, and there's maybe some concern about, you know, how pure or clean that supply is, you know, is there any sort of adulterant that a patient may come across if they're using something that was mixed elsewhere, et cetera. For our patient, you know, no smoking, no very little alcohol use, no other drug use. So not relevant in her, but can be very relevant in patients with bleeding in general. And then moving on to the exam. So this patient is hypotensive, 85/47. I love your idea about getting orthostatics. I think we should definitely get orthostatics. Her heart rate is inappropriately normal, which may be because she's on the beta blocker and because she's an older patient. So she may not be able to mount that same sort of compensatory tachycardia. And in the exam, you know, I agree that clinically, it doesn't seem like there's a place that she's necessarily losing all of this blood. The one thing that worries me, the one place, there are a couple of places where you can lose a lot of blood where it's not very apparent on exam: the thighs and the retroperitoneum. So my threshold to get a CBC with differential, get coag studies, including an INR and PTT, and then especially if she has orthostatic signs that are, you know, signs of orthostatic hypotension or worsening of her hypotension with standing up, my threshold to both kind of volume resuscitate this patient and get further imaging, like CT imaging, is very low. Because the first thing is going to be, you know, if she's actively bleeding, we need to stabilize her. And then we can sort out why she's actively bleeding kind of a little later down the road. So those are my thoughts to add to what you had put forward.
So I'm gonna give the labs. White blood count was 10.3. The hemoglobin was 6.1. And the platelets were 264,000. The MCV was 103. Her sodium was 132. Potassium 4.5. Chloride 104. Bicarb 19, BUN 30, creatinine 1.31, and glucose 104. Her AST was 31. Her ALT was 9. Her total bilirubin was 1.5. Her OCPHOS was 73. Her total protein was 6. And her albumin was 3.3. When it comes to coags, her INR was 1.1, PT 13.8, her PTT was 72.9, which is high, and her fibrinogen was 346. And there one more additional lab. Russell Viper Venom time was normal. and her APTT mixing study was 97.8, which is high. And there are 2 more aliquots.
Amazing. Thank you, Rafa. So a lot of data, Leo, that came our way. I'm curious what is standing out to you here and how are you putting this together with sort of our discussion so far?
Well, what worries me here is the grade of anemia she has. I'm wondering if that is acute because of any blood loss, like Anand mentioned, in maybe a non-apparent site. So I'm thinking about that, but also considering the possibility that is a chronically developing anemia that comes for a long time, or maybe a bit of both, maybe an anemia that is chronic and now has exacerbated because of an acute blood loss. I don't see any leukopenia or any. Sorry, I don't see any leukopenia or plaquetopenia, only anemia. So I'm not thinking about platelet, at least not a lack of platelet, maybe platelet dysfunction. But what calls my attention is the prolonged PTT. So very altered. I don't know what's the normal value for the laboratory. Here is about 36, 40, so 72 is a lot for us. I'm not sure about the normal value of the fibrinogen. Is it elevated? I don't remember. Sorry. It's not elevated. Okay. So okay. So I'm thinking about the problem in the coagulation cascade, but combined as well. We will have to see there is macrocytosis as well. So there is a severe macrocytic anemia. Again, I'm wondering if that is acute or chronic, because I'm thinking the coagulation problem is somehow acute, and that prolongation of the PTT is acute as well, and maybe that has caused that severe anemia. But also the macrocytosis could point to maybe an hematologic problem, like Maria mentioned before, myelofibrosis, for example, or another bone marrow issue. I see that there is no, at least, I believe the albumin is a bit low, yes, but not so much. So, and the rest of the hepatic labs appear to be normal. The ionogram is normal for me, and I saw an elevated creatinine. Maybe that is, but the urea, the BUN is normal. I don't know, because of the age of the patient, she might have maybe some chronic renal dysfunction. She is hypertensive patient, so maybe some degree of something there, but I'm not thinking something acute, like acute renal failure because of hypovolemia or something like that, because the BUN is normal. And well, I think this degree of anemia, again, points out to the importance of what Anand mentioned, and also explains the slight hypotension the patient has, and the progressive fatigue might point to something more chronically developing. And also, well, I believe that the symptoms somehow fit with the laboratory we are seeing. I would like to see a smear, a peripheral blood smear, to see the morphology of those red cells that are macrocytic. These patients, older patients not always eat well, so that might be related to some degree of lack of folate or vitamin B12, but I'm also worrying about maybe a bone marrow problem with that. So I think we should quickly find out if there is any bleeding, like Anand mentioned, and also try to correct that altered PTT.
Leo, this was such a masterful discussion, again, laying out so clearly your approach and anchoring on sort of the most concerning findings, which I agree with you. In this case, we were worried about bleeding, and then now we see a low hemoglobin and hypotension. Just as Anand and Maria said, I think the first order of business is whenever I think about anemia, I think about time course, so acute versus chronic. And we have to assume it's acute until proven otherwise, because the acute causes of anemia are the most morbid one, right? And so acute anemia with hypotension, we have to go looking for bleeding. And the best thing to do, even before a CT scan, is you have a bedside ultrasound. If you have one, we can perform a fast exam. And so that can quickly tell us if there's any big pockets of bleeding, because in this case, we may be going down the route of management before we think about diagnostics. So that's sort of the first point around the hemoglobin with the hypotension, is thinking about treatment first. And then I agree with you with that MCV being 103. The mean MCV, and Anand can correct me if I'm wrong here, for a reticulocyte is about a 105. So to me, that suggests there is potentially active bleeding, and the bone marrow is potentially revved up and trying to make more red blood cells. And that's what's kind of increasing that average, the mean, the MCV here. And so would love to see a blood smear, would love to see a reticulocyte count, would be really interested in seeing an LDH as well. And then the other thing, whenever I see, anemia, I assume it's acute. And then the next thing I do is I look at the platelets. Because if we have anemia plus thrombocytopenia, there are a whole host of other emergencies that we won't talk about, including mostly the MAHAs that we need to be considering. That in this case, I think we feel okay that the platelet number at least is okay, although to your point, potentially the platelets themselves could be less functional. But we have an explanation for the bleeding with the low hemoglobin. And then we see, we get some of this really interesting, rich data on the coagulation studies. And so with the PTT being elevated and the Russell Viper venom time being normal, to me, that test, the Russell Viper venom study, is looking for, is there the lupus anticoagulant that is present that is artificially increasing the PTT? So the fact that the Russell Viper venom study was normal suggests to me that we're probably not dealing with a situation in which the PTT is artificially being elevated from a lupus anticoagulant. Then we get to the mixing study, which if there was a deficiency of a particular factor, it should be corrected by the mixing study. But the PTT continues to be prolonged despite the mixing study, suggesting it's not a problem with a deficiency in the number of coagulation factors, but rather there is probably the presence of an inhibitor in this case. And then when we think about, well, why would an inhibitor be present in an 81-year-old woman? We start to think about sort of acquired causes of factor inhibitors. And the most common cause of an acquired factor inhibitor is, or the most common type of acquired factor inhibitor is an acquired inhibitor to factor 8. I believe the next common ones are 9 and 11 as well. And so I would be, and I would be sort of kind of exploring that pathway to see, do we have a factor inhibitor in this case? First thinking about treatment, and then thinking about in terms of diagnostics, is there a factor inhibitor with the most common cause being for factor 8? And then some of the other laboratory studies that stand out to me with this, that's been so helpfully highlighted in red. The hyponatremia, we have this hypothesis that maybe she's bleeding, she's pretty hypotensive. And so this, I think, is another indication that this patient probably needs to be fluid resuscitated. And then with that creatinine, again, being elevated, again, my first pass hypothesis is usually, AKIs in the hospital are pre-renal. And so you can't really make much progress on that until you've fluid resuscitated the patient, and unless obviously they look floridly volume overloaded. But in this case, I would want to fluid resuscitate, give the patient blood, and sort of see what the labs do. One of the hypotheses that that Maria had brought up was, and that Leo, you mentioned as well, is there kind of a smoldering process underlying this, like a myeloproliferative disorder that then, gets tipped over? Interestingly, we see that the albumin is 3.3 and the total protein is 6. So we don't have a protein gap here. And so it makes me slightly less suspicious that there was an underlying myeloproliferative disorder. But certainly, she could have a bone marrow that's just burnt out and not making as many cells. But putting all of this together, I completely agree with you. I think we're looking for bleeding. We're going to treat the bleeding. And then with the mixing study, we're worried about an acquired factor inhibitor.
Incredible discussion. So there are two aliquots. One is about imaging and the other is additional labs, which will reveal the final diagnosis. So I'm gonna say just the imaging right now. So a CT chest of the abdomen, the CT of the chest, abdomen and pelvis only showed a solid right adnexal mass. The measure is 6.2 centimeters. And this patient also has cardiomegaly and atherosclerotic vascular changes and presumed adrenal hyperplasia and also diverticulosis. And there's just one more aliquot, which will reveal the final diagnosis.
And to confirm, Rafa, that was an adnexal mass you said that was seen?
Yes, adnexal mass.
Wonderful, thank you. All right, Maria. So how do we layer on our thoughts about this imaging to the wonderful discussion that Smitha and Leonardo just walked us through with regards to the labs?
Yeah, I agree. The discussion was amazing, and it brought us like super close to like getting the final answer. We know there's bleeding, we know there's probably a factor inhibitor, and it has to be somehow acquired because she didn't report these problems ever before in her lifetime. And now we layer on the fact that she has an adnexal mass. It doesn't, you know, like we don't have any more characteristics to define if it's probably like benign or like cystic, or does it look like in any type of malignancy. We don't know if it's like bleeding into the mass, which I don't think so because it looks pretty small. And so I'm wondering if this is some sort of malignancy that is causing the factor inhibitors, because I know that some of the acquired causes can be, malignancy associated. I don't know if it's driven by like a paraneoplastic syndrome or the malignancy itself. And, with the other things, with like the cardiomegaly, atherosclerotic changes and diverticulosis, that doesn't seem specific. She's an older patient, so she's bound to have many more diseases than a younger patient. And I don't think they give us much more information. So right now I'm just like wondering, what else can we know about this adnexal mass, and how worried should I be based on like the characteristics of the imaging? And then maybe that can explain the factor inhibitor, or maybe it doesn't. But yeah, that's what I'm thinking.
I love that, Maria. And I think, in my mind, this imaging tells us, thankfully, that it doesn't seem like this patient has had a large volume of blood loss into, like one of the abdominal cavity or the thighs or anything like that. So hopefully, if all of this bleeding is kind of happened, but is relatively slow, and it's basically these ecchymoses are the kind of the evidence of our patient losing blood, volume resuscitation with something like packed red blood cells will get her feeling better, and hopefully she'll be hanging on to those packed red blood cells pretty well. So there's not like an actively bleeding lesion that we need to go after and try to have our IR colleagues embolize or something like that. So I think that's somewhat reassuring. This adnexal mass worries me. 6.2 centimeters is quite large. I think this also brings up a very interesting kind of management question, in that the best way to figure out what's going on in this adnexal mass is probably to biopsy it. I would not want to biopsy this patient right now. I think we need to correct our patient's propensity to bleed and this coagulopathy. So that brings us back to much of the conversation that Smitha and Leonardo had, which I'll kind of just briefly touch upon again. Based on everything we know, it's very likely that this patient has an acquired inhibitor. When thinking about the most common acquired inhibitors, as was said, factor VIII is the most common. And most commonly, when you think about underlying etiologies of a factor VIII inhibitor, while a large percentage of them can be either autoimmune or idiopathic in etiology, malignancy is a very big part of the pie. And that includes both solid malignancies and hematologic malignancies. So in a patient with an adnexal mass and laboratory evidence that gives us high concern for a factor inhibitor, those would be things that would be on my mind. The other thing to think about is when we're talking about treating acquired factor inhibitors, there's kind of two components to it. There's what do you do acutely and what do you do in the long term? So in the long term, the goal is to get rid of that inhibitor. Most inhibitors are made by B cells. The best way to get rid of an inhibitor is to kind of turn off those B cells. So you can give them a CD20 drug like rituximab. The problem is that usually it takes several weeks for something like rituximab to work. Sometimes high-dose steroids can be helpful as they're lymphotoxic. But for someone like this who may need a procedure fairly quickly, or in someone who's having active bleeding, what are used are bypass agents. So things like factor 7. So factor 7 doesn't need you to have factor 8. So you could, if your hospital, say, carries recombinant factor 7, and this is where our pharmacy colleagues are so incredibly helpful, is talking to them about what we have, because every hospital is a little different in terms of what sorts of synthetic products they have when it comes to managing inhibitor deficiencies. So talking to your pharmacy colleagues and figuring out what's the right kind of thing to reach for this patient, whether it be factor 7 or some other sort of bypassing agent. So those would be the things on my mind is how do we safely, that this patient needs packed red blood cells. How do we safely get after this ovarian mass? We should send off tests for inhibitors to look for a factor 8, factor 9, factor 11 inhibitor. And in the meantime, we should try to correct this patient's PTT if we're able to, and then think about how to best sample this adnexal mass.
So the final adequate, it's about the labs. The factor 7, 9, and 11, all their activities were normal regarding those factors. The factor 8 activity was low. The von Willebrand factor activity was high. And the factor 8 inhibitor was really high, like it was 62.4, and the normal is 0 to 0.4.
Thank you so much, Rafa. Is that the end of the aliquot? Thank you. Awesome. Leo, any reflections on this final data that we got?
Yes, well, I'm surprised. I have actually never before given much attention to the factor inhibitors. I knew, like Maria mentioned, they were sometimes related to paraneoplastic syndrome and neoplasias. And I think that's the interesting thing of this case, or at least what I'm taking home as a teaching point. That always in this age group of patients, neoplasias have to be really in front of our minds to think, and especially when they present with fatigue or some kind of anemia and some other hematologic alteration, like today, like the spontaneous bruising. So in that case, our approach, it's really interesting when you don't have a lot of resources to think about the prevalence of these different neoplasias in these patients, to somehow evaluate them like in order of prevalence, not to rule out, because not always we can do like a whole body CT, for example. So maybe thinking there about the prevalence, and here the family history of the patient somehow can point out to a kind of tumor that we can look for. In this patient, it was necessary to do that whole CT because of the looking for an active bleeding, but I think it was really interesting the kind of tumor it was found. I think it's interesting that there are some types of ovarian cancer that are more types of histology in ovarian cancer that are more related with the paraneoplastic syndromes. I don't recall much of that, but I believe it is the mucinous type that is more related with these kinds of alterations, but I'm not sure. I'm not really sure. But, and again, I think it was really interesting, the case. I love oncology, so for me it's always interesting to hear these kinds of cases. And I think I learned a lot about the management, especially of the altered coagulation cascade here and the inhibitors. And well, like adding on top of what Anand said before, I'm thinking about ovarian cancer can be another type of thing responsible for the mass, but I'm thinking about that. So we know that they are not biopsied like percutaneously. You have to do an open surgery in ovarian cancer. So that gives us like a bigger reason to somehow resolve the coagulation alteration beforehand, and then probably doing the surgery and treating the neoplasia adequately. But and I'm not sure, and I would like to hear, like someone in the chat said, from Anand, what can we do acutely in this patient to somehow correct the APTT that is altered? I would love to hear and learn that today.
Of course, that was such a wonderful discussion and reflection, Leo, and would love to learn more, just as you said, from Anand, our in-house hematologist and oncologist. I just thought this case was so elegant. Thank you, Rafa, for bringing it to us. We started with this elderly woman with bleeding, and then we asked sort of why she's bleeding. We found this factor inhibitor, and then the story didn't end there. We continued to have to ask why, and we landed at this malignancy. And so my only other learning point that I realized, we reviewed the whole clotting cascade, which was wonderful. When I heard Rafa say the von Willebrand factor was high, I was reminded that when you have what looks like deficiencies in factor VIII, thinking about von Willebrand factor is really important, because having von Willebrand factor is essential to maintaining normal factor VIII levels in circulation, because it actually stabilizes the factor VIII and prevents it from being degraded. So thank you, Rafa, for reminding me of that. And I just learned so much. Thank you all for such a wonderful discussion. And I'll turn it over to Maria and Anand to see if you have any other thoughts or reflections.
This was such a good case. I feel like, like I've told you before, I'm really scared of heme, but any day I understand a little bit more of it, I'm like, wow, this is such a cool thing to know. Because, we covered everything from the coagulation cascade to platelets, and it's really nice how each factor or something relates to a disease and that presents clinically. At the beginning, when I started studying, I felt everything seemed like the same. All the leukemia seemed the same. All of the bleeding abnormalities seem the same. And then you can check for really subtle differences between all of them. And yeah, it just motivates me to keep studying.
Yeah, I mean, I just want to say, Maria and Leonardo, you guys did all of the heavy lifting today. I like to say you picked the bones clean. There wasn't much for me and Smith to go after with each aliquot, which is wonderful. And you guys just took a very sick patient and still kind of stayed systematic with how to work through what was going on with this patient and ultimately get to our final diagnosis. A couple things that I'll add based on what was in the chat was, one question was, what would happen if the mixing study corrected? And if a mixing study corrects, so if you have a high PTT and so essentially the way a mixing study works is you take serum that you take plasma that has adequate amounts of factors. So if you give that to someone who's factor deficient and there's no inhibitor, those mixing times should all correct, because we essentially have more factor than we need. Even if you have 50% of a factor VIII level, you're still going to have normal clotting times. So if someone's PTT corrects with mixing, then you start worrying about, do they have a true deficiency of a factor? So in our very young patients, that could be something like hemophilia A, hemophilia B that they were born with. They were born with this deficiency. In older patients, the biggest driver for that is either they're on a medication that's causing it, like warfarin. So warfarin's going to deplete many of your factors, or they're functionally deficient in a nutrient like vitamin K. When people talk about, well, warfarin, based on the factors that it impacts, it should only impact the PT and not the PTT. In reality, if patients have a very super therapeutic INR, so very high, or they're extremely deficient in vitamin K, they can have prolongations in their PTTs as well. So in an 81-year-old who had a mixing study that corrected, I would start thinking about what could be things that could be causing a true deficiency in clotting factors. I don't think this is something that she was likely born with. And then I'd start thinking about, was there accidental exposure to something like a vitamin K antagonist that she didn't know about? Are there things going on socially that are preventing her from having appropriate dietary intake, or are there dietary restrictions that she partakes in that may not allow her to be able to eat adequate amounts of things like vitamin K? Those would be the things that were on my mind. And I think the one other thing I'll add is there's it's so important to know, and Anne-Marie put this in the chat as well, the list of diagnoses that aren't really the end diagnosis, and a factor VIII inhibitor is one of them. You have to kind of keep chasing to figure out why it is that this patient has a factor VIII before you say this is idiopathic, and we really, because until you treat that underlying cause, this patient is at risk of having a relapse or a flare of their acquired factor VIII deficiency. So with that, let's turn it over to Gurleen, who's compiled a great list of teaching points to run us through.
Just to finish, this patient was ultimately diagnosed with factor VIII inhibitor disorder. They actually did a biopsy, but it was not malignant, and the acquired inhibitor was deemed idiopathic in nature. And this patient was discharged with prednisone and tranexamic acid as well.
Thank you so much, Rafa, for presenting that case. I learned so much from the discussion. So just going over and recapping some of the key points from this case. So initially, the chief concern that we were discussing was bleeding. So when we're thinking about bleeding in any patient, we want to first frame the patient. Is it traumatic bleeding? Is there a high risk for falls given the age of this patient, or is it non-traumatic in etiology? Other things would be inciting factors like medications like anticoagulation that the patient could be on, as well as other drugs that could be mixed with things that are similar to warfarin and could lead to bleeding. And then the other thing would be to ask about previous procedures, and younger patients' family history is really important when thinking about bleeding disorders. So the overall approach when we're thinking about bleeding, we're thinking about what the components are for clotting. So the components include platelets, and in terms of platelets, it could be a quantitative issue or a qualitative or a functional issue. So when we're thinking about quantitative issues, things like ITP, TTP, and then thinking about functional issues that are causing the platelets to not be able to have their full function. And then coagulation factors would be the other aspect of coagulation, as well as mechanical issues in terms of the integrity of the vessel wall. So when we're thinking about vessel wall integrity, thinking about genetic conditions like Ehlers-Danlos syndrome and connective tissue collagen dysfunction, which could be inherited, but also could be due to vitamin deficiencies like vitamin C deficiency with scurvy. And then thinking about things that can also deposit in the vessel wall and lead to impairment of the vessel wall integrity, things like amyloid. And then when we were approaching this patient, we were trying to collect clues to see what else is going on to layer upon the initial symptoms of bleeding and ecchymoses. So in this patient, there was the fatigue, which could point towards a more chronic process that could be going on. The other aspect was in this patient, the hypotension and the instability is really important to first address to make sure that the patient isn't losing a lot of blood somewhere. And sometimes tachycardia can be masked with like beta blockers. So it's important to keep that in mind when you're seeing a patient who isn't having an elevated heart rate, but if they're on something like metoprolol. And then we're thinking in this patient, there was anemia with the low hemoglobin and the MCV was high. So when we're thinking about anemia overall, want to always remember acute versus chronic. And initially with a patient that is hypotensive and is having anemia, always want to assume that it's acute and act upon that. And in terms of the macrocytic, it could be due to vitamin deficiencies like B12 and folate, but also if you have a high reticulocyte count, that can lead to an elevation in the MCV. So that's also important to keep in mind. And then when we were the final kind of the main like pivot point of this case were the coagulation studies and the mixing study. So when we're thinking about a mixing study, Anand explained all of most of what I had on the teaching points. So just to recap a little bit, if the mixing study corrects, then it's a deficiency. It's an intrinsic factor deficiency, which could be due to inherited disorders like hemophilia A or B in younger patients, or in older patients thinking of medications like warfarin and other things. And then if it does not correct, so if you have the patient's plasma and you add normal plasma to it and it doesn't correct, that means that there is an inhibitor present. And that inhibitor, the most common, when we're thinking about base rate of disease, the most common acquired factor inhibitor is for factor 8. And when we're thinking about acquired factor inhibitors, the different causes would be autoimmune, idiopathic, or malignancy. So when this is an example of a diagnosis where the final diagnosis of an inhibitor isn't just the final diagnosis, you have to delve deeper into what's causing it. And in terms of treatment of factor inhibitors, as Anand pointed out, there's the acute management and the chronic management, with chronic management being focused on B cells because those are the ones producing the inhibitors. So it's things like rituximab, which are anti-CD20. So thank you so much, everyone, for joining. And yeah, thank you. It was such a great discussion. I learned so much today.
Thanks for joining us, everyone, and enjoy the rest of your Monday.
Thanks, everyone. See you all soon.